arrhythmias. For purposes of the exam, because this is not a rhythm interpretation class. This is not a ACLS class. What we're doing today is just for the NCLEX. What we need for the NCLEX are commonly occurring dysrhythmias. So we need to recognize, we need to know what they look like. We need to know what causes them. We need to know the signs and symptoms, and then the intervention, and then the teaching. Okay, so there are common dysrhythmias found in this chapter. Now, as to the first item, which is how to recognize it, I can only use the rhythm strips that are used in the textbook, because let's say atrial fibrillation, it can look probably 15 or more different ways. AFib can look several different ways. So because you don't have any experience with looking at AFib yet or any other dysrhythmia, so it's only fair that I use the ECG strips that are used in your textbook. Okay, so that answers number one. Number two is we need to know the causes. Why do you think we need to know the cause? Okay, so that your interventions will be geared toward the cause. Very good. And then number three is the easy part. Signs and symptoms are similar, because whether or not the rhythm is sinus or otherwise anything serious, what will happen to the cardiac output if there's an abnormal rhythm? It will drop. When cardiac output drops, will the manifestations be different? It'll be the same. The severity of the manifestations, of course, will vary. You understand? Okay, and then the interventions, we have three sets of interventions. One is non-pharmacologic. Second is pharmacologic, meaning we'll use medications. And then third, doctors may perform invasive or non-invasive maneuvers in order to treat the dysrhythmia. And finally, number five, we will teach the patient about the dysrhythmia. What do you think will be the content of your teaching? Will it be anything different than causes, signs, and symptoms? Okay, the same. All right. So let's answer 5 questions for each dysrhythmia that we will cover today. Let's review first the normal and electrical conduction. Let's look at what are we looking at when we are monitoring somebody's cardiac monitor or on a 12-lead ECG, for instance. Okay. Now, there are certain terms here, and let's look at first how our heart works. So the normal electrical conduction of the heart is generated by the SA node. SA node, also called the sinoatrial node. It is located in the right atrium, right at the entry of blood in the right atrium. Now, unlike other cells, which cannot generate its own electrical impulse, meaning, I'll give you an example. You know, someone, or have seen in movies, when someone has a spinal cord injury, what happens to the level of functioning below the level of injury? Like, what happens to the sensory and motor function below the level of injury? So let's say you broke your neck. What happened to the sensory motor function from your chest down? 0 or absent, right? I mean, decreased or absent, correct? Okay, so therefore, what can you say about skeletal muscle cells? Can they generate their own electrical impulses? No. They cannot. They depend on sensory neural innervation, meaning without the brain sending impulses, electrical impulses to control them, your muscles become useless. You understand? Okay, meaning if there is no electrical stimulation of the skeletal muscles, they cannot move. You cannot feel anything. Unlike the heart, whether or not there are electrical impulses from the brain, the heart can generate its own electrical impulse. We call that, what did Dr. Farrington's call that? Action potential, right? So meaning the heart, courtesy of the SA node, can generate its own electrical impulses. It can stimulate itself. So there's some truth to, you've seen in movies wherein some expert martial arts guy rips somebody's heart out from their chest, and then the heart continues to beat. There is some truth to that. However, there has to be blood supply, continuous blood supply to the heart in order for this to happen. But meaning we can keep a heart organ alive outside the body as long as you keep feeding it oxygen and sugar. Does that make sense? Meaning the heart can do that, meaning it doesn't need the brain in order to function. Unlike all other skeletal muscles, do they need the brain in order to function? Yes. However, have you ever seen a comatose patient move? A brain dead patient move? No, because the brain needs to control the skeletal muscles. However, have you seen a comatose patient who's brain dead and the heart is still functioning? Yes, because of that fact. You understand so far?
Yes.
All right. Let's review a few terms here. Conduction, what do you mean by conduction? Okay, so the traveling, meaning our nerves can pass electrical impulses, and so that applies to cardiac muscles as well. So they can pass along electrical impulses. Another term is depolarization and repolarization. When we say depolarization, that simply refers to contraction. Okay, mechanical contraction. In this particular matter, we're talking about the heart muscles, the chambers of the heart. How many chambers do we have? Four. We have two atria, we have two ventricles. So when we say depolarize, that means they are contracting and they are pumping blood outside the chamber. And when we say repolarize, that means if it depolarized, it has to repolarize. Okay, this is also called relaxation. Now, when we look at the electrical activity in a resting cell, so let's say this remote control is a cell, single cell example. When we say depolarize, that means inside the cell, we have cations, right? And anions, we have sodium and we have potassium electrolytes, okay? So they come in and out of the cell. When they do that, they polarize the cell, meaning it generates electrical activity. So when you push sodium and potassium in and out of a cell, that creates energy, that creates electricity. Okay, because they are positive and negatively charged. So therefore, what's pushing the electrolytes in and out? What's making that possible? Are they pushing themselves in and out? No, that is caused by blood pressure. So as blood is circulating through the capillaries, arteries, veins, when there is enough pressure, these cations, sodium, potassium specifically, and including calcium, they are pushed in and out of the cell. And in that process, electricity is generated. Okay? So that's why when we get to defibrillation, what do you understand by defibrillation? You've done BLS. So what does defibrillation mean? Using an AED? Okay, delivering an electric shock, right? So we call that defibrillation. So therefore, there are only two rhythms that are going to be defibrillated. What are they? What were the two abnormal rhythms that can be defibrillated? Ventricular pulseless ventricular tachycardia and ventricular. Go ahead. Yeah. No, not AFib. VFib. Okay, so only ventricular fibrillation and ventricular tachycardia. The reason why we do not defibrillate asystole, what is asystole? Flat line. So when it's flat line, that means what? Is there any electrical activity? None. So therefore, can you shock something that if there is no rhythm? No, because if you shock them, you're simply cooking the patient. You are electrocuting the patient. You might as well smother them with barbecue sauce first before you defibrillate, because at least they'll taste good. All right. So we do not shock asystole because there is nothing to convert. Okay, there is nothing to defibrillate. The patient has no electrical activity. So you have to generate electricity first. How? What's the only treatment for asystole? Again, you all are BLS certified. So what's the only treatment for asystole? Chest compression. So why are we compressing the chest? What are we trying to generate? Electricity. So the only way to generate electricity is to keep blood circulating. So that's why you're squeezing the heart, you're compressing the chest so that blood continues to move. And then once blood is moved, is there pressure now?
Yes.
Are you pushing the electrolytes in and out of the cells now? Are you generating power? Yes. Now, the first rhythm that returns when you perform chest compressions is usually either ventricular fibrillation or ventricular tachycardia. And then you can shock the patient. Okay. All right. Let's go straight to the heart. We established that the heart can function independently of the brain. You agree?
Yes.
Yes, it doesn't need the brain to function. It can generate its own electrical impulse as long as it receives circulation, meaning there's blood flow to the coronary arteries, and there is electricity being generated. However, it doesn't mean the brain cannot control the heart. It can. Again, the heart does not need the brain to function. However, can it be affected or controlled by the brain? Yes, we have a few terms here. Let's just focus on sympathetic and parasympathetic nervous system hormones, for instance. So, can your heart rate be increased or decreased by the brain?
Yes.
Yes, by secreting hormones. Okay, so we have pituitary hormones, we have adrenal hormones. So here are activities that will cause sympathetic stimulation: exercise, anxiety, fever, or given drugs, sympathomimetic drugs like dobutamine, aminophylline, dopamine. We'll get to know those drugs later. Or we have parasympathetic stimulation, which means rest and digest, correct? So if sympathetic causes increased heart rate, increased blood pressure, and vasoconstriction, what will be the effect of parasympathetic? Okay, so it will cause bradycardia, low blood pressure, and vasodilation. Okay, so here are some effects. So as early as now, do you have any idea about what can cause dysrhythmias? We just talked about it. Yes. So sympathetic stimulation, such as these here, can do what to your heart rate? Increase it. Whereas what will be the effect of these here? Decrease your heart rate. Okay. Let's talk about the ECG. ECG, the minimum here is a 12 lead ECG. There are, of course, 1 and 6 lead ECGs. However, in order to make a complete diagnosis of a patient's dysrhythmia, a doctor will require a 12 lead ECG. So when you're asking yourself, let's say you work in telemetry, ICU, and then the patient is on a cardiac monitor, and then you report a dysrhythmia to the physician, and then physician orders you to get a 12 lead ECG, you may think, I just told you what the patient's dysrhythmia was. I printed a strip for you. Why are you asking me to do a 12-lead ECG? Well, the telemetry, the cardiac monitor that you see, which has about 5 leads, 2 in each arm, 2 in each leg. No, sorry, 1 on each arm, 1 on each leg, and then 1 on the chest. So that's 5 electrodes, right? So therefore, that only gives you about 6 leads. It doesn't give you 12. 12 lead, there are 2 meanings to the lead here. When we say lead, we are, of course, referring to the leads, okay, the cardiac electrodes that we put on the patient's body. However, in the 12-lead ECG, the lead there is really referring to view. Lead, again, can mean the physical electrode that you put on the patient's body, and it also refers to the views that the 10 electrodes will give you. Now, long story short, because it's a long story to explain the Einthoven triangle. So this is the Einthoven triangle. Einthoven triangle, it's called that because of the person. He's given credit for inventing the 12-lead ECG. And he explained it via the Einthoven triangle. So it's an upside down triangle showing you the interactions between positive and negative terminals of the 12-lead ECG. So for example, in the right arm, these are both negative terminals, whereas the left arm has a positive and a negative. And of course, the left leg will be both positive. Now, as you may have recalled in high school about basic electricity or electronics, what happens when you have a positive and a negative terminal? Okay, electricity will be created, and can it be conducted? Yes. Can there be a reaction if there are opposite poles versus same poles? By poles, I mean, electrical pole. Yes. The reason why you don't see a right leg here is the right leg lead really doesn't carry anything. So it's neither negative or positive. It's only a ground lead. Now you understand why there is a ground, meaning every electrical outlet you see there is a ground lead there. Okay, there's a positive and a negative wire, correct? And then why is there a green wire? What's the purpose of a green wire? The ground lead. So that electricity will will pass through the circuit, because otherwise it will go into the ground, correct? All right, so that's the purpose of, so the right leg here, because we're going to put a lead on the right leg. The right leg is simply a ground lead. Okay, so it's only the left leg that carries electrodes, both positive. So here's the placement of your 12-lead ECG. As you can see, there are 10 electrodes only. 10 electrodes which interact, giving you 12 different views. All right. So here's the placement. So anybody can do it. The electrodes are labeled RA, left LA, V, V1, V2, V3, 4, 5, 6, LL, RL. All right, you can't miss it. Okay, so this is the placement. So V1, V2 will be on the second intercostal, left and right sternal borders. And then your 4, 5, 6 will be third, and fourth, and then all the way to mid-clavicular and mid-axillary. Okay, so you put them here, 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 and here. All right. ECG machines are easy to use. It will tell you exactly what's wrong. So let's say you have a very hairy Italian, for instance, for a patient. Will the electrodes have good contact to the skin? No. And of course, the ECG machine will tell you exactly which electrode has no contact with the skin. So it'll turn red, and it will only turn green once you have good contact on the skin. Okay, very easy to use. Once you have everything, all 10 electrodes green, then it will give you a reading, and then you can print it when you're ready. Now let's go back to the triangle. Which direction is the electrical conduction taking? Okay, let's look at the pacemakers of the heart. We have three sets of pacemakers. Pacemakers meaning cells that generate electrical impulses. Okay. First one and the primary pacemaker is the SA node. So this is the location of the SA node. Now, this doesn't mean that only the right atrium will contract. There are interatrial branches, as you can see here. There are interatrial branches, meaning the SA node extends its arms to the left atrium, making the atria, both atria, contract at exactly the same time. Because when you've seen electricity, right? The best example is lightning. So we've had lightning storms in our lives. We've seen it. So how long did it take when the lightning lit up and then hit something in the horizon? Did it take long? Were you able to finish a bite? Or will you able to blink before it's over? No. No, you can't blink because otherwise if you blink, then you wouldn't have seen it. So that means it's so fast that you weren't even to finish a blink. Okay, it's that fast. Although, is diarrhea faster than the lightning or not? Yes, diarrhea is the fastest, right? It's already there before you can blink, right? Yes?
Yes.
Yeah, you soiled your shorts at some point, right? Yeah. No, I'm just kidding. Okay, so the electricity, of course, is the fastest. So that's how fast it will travel from the SA node to the left atrium. Because it's a primary pacemaker, it has certain characteristics. It can fire between 60 to 100 times a minute. There is a secondary pacemaker called the AV node. So this is located between the atria and the ventricles, right at the septum. It is called the secondary pacemaker. It's also called the backup pacemaker, which means if the SA node fails, meaning there's something wrong with the SA node, or if the AV node doesn't receive any impulses from the SA node, the AV node can fire because it's also a pacemaker, just like the SA node. However, unlike the SA node, which can fire how many times? 60 to 100. The AV node can only fire between 40 and 60. So is it as efficient as the SA node?
No.
No. Better than nothing though, right? I mean, better than less, but because it can fire 40 to 60. However, because it can only fire between 40 to 60, can it sustain life forever?
No.
No. Can it sustain life for a while? Yes. The third set of pacemakers are the left and right bundle of His, and then all the way to the Purkinje fibers. They are also pacemakers. However, they are not worth talking about because they can only fire between 20 and 40 times a minute. Is that compatible with life?
No.
Can it even keep the patient alive?
No.
Not at all. So we typically don't talk about them as pacemakers because, I mean, they're useless. Okay? So the two main pacemakers are really just the SA and the AV node. So this is called sinoatrial node. This is called the arteriovenous node. Okay, AV node and the SA node. So therefore, if this is my heart right here and it's tilted toward the left, correct? The heart is at the center in the mediastinum and it's tilted toward the left. That's the position of the heart. So therefore, looking at this, if the electrical impulse is passed from the SA node to the AV node and then to the left and right bundle of His, which direction is the electrical conduction going? Is it straight down or toward my left foot? Toward my left foot. Now, which lead is parallel to that electrical conduction pathway? Lead 2. So this is lead 1 up here. Lead 2 is on my right. Lead 3 is on my left. All right. So therefore, which lead again is parallel to that electrical conduction pathway? Lead 2. So for purposes of all the illustrations in chapter 22, most, if not all, the ECG leads shown here or used here are coming or taken from the second lead, from lead 2. Let me show you a 12 lead ECG and explain why are there 12 different views. Okay, so what are we looking at? Nothing. Okay, so you're looking at a 12 lead ECG. You'll see here there's 1, 2, 3, V1, V2, V3. Should say V3. And then we've got AVR, AVL, AVF, V1, 2, 3, 4, 5, 6. So 1, 2, 3, AVR, AVL, AVF, V1, 2, 3, 4, 5, 6. How many leads are there? 12. But if you look at the leads and the appearance or the picture of the waves and complexes, do they look the same from one lead to another? No, they do not. Why are there therefore 12 different views depending on which lead? So I showed you the placement of lead 2. Lead 2 is taken from the right side. Lead 3 is from the left side. Lead 1 is from the head. Left leg, of course, is from the left leg. And to complicate a few things further, this left arm here, because it has a positive and a negative terminal, unlike the others, this is positive, positive, this is negative, negative. The left, the view from the left arm is actually taken from the right shoulder. So this is what I mean by I'm just giving you a crash course because it's very complicated to explain. However, this, I'm just trying to impress upon you why there are 12 different views. Imagine this in a way wherein there are 12 different photographers taking a picture of the heart, taking a picture of the electrical conduction of the heart from a different vantage point. Does that help? Meaning each of these photographers are sitting on a different pedestal around the heart. Meaning, will they give you different pictures? If they are, let's say there's a photographer over my left shoulder, another from my right shoulder, all taking the same picture of my heart, will they give you the same pictures? No, because, right, it'll be different because let's say lead 1. Where is lead 1 taking the picture from? From my head. So therefore, lead 1 and lead 2, will they show you the same picture? No. So does that make sense? Now, why does the doctor order a 12 lead ECG? Well, this will help them identify where is the problem coming from, particularly which coronary artery is affected. Right? So let's say when we talk about a heart attack, which we'll talk about next semester, acute coronary syndromes. So this information can be taken from a 12 lead ECG before they go into the cath lab. Make sense? Okay, so they can see, oh, because this is, of course, I don't have time to explain why, because that's a whole semester course on cardiology. But knowing electrophysiology, the doctors are trained to know, okay, because this is the ST and T wave changes are occurring. So let's say in V1, that means, oh, this must be a right coronary artery problem. Okay, and then they can make a next testing. So they'll take the patient to the cath lab and go from there. Make sense? Any questions so far? I mean, this part isn't testable, okay? I'm just trying to explain what a 12-lead ECG is and why it gives you 12 different views. Any question? Okay. Okay, let's go now to what does each wave and complex represent? Okay, let's look at this figure. Figure 22-3. So this is a P wave, and then we have a QRS complex, and then this distance here is called the ST segment, and then now we have a T wave, and then we have a U wave. For today's purpose, we will not talk about the U wave because the U wave is probably present in every 1 out of 100 cardiac monitors. What I'm saying is the U wave does not appear very often. Does that make sense? Do you understand? Meaning you typically won't see a U wave. So we'll talk about it when we see it. But most ECG strips will not show a U wave. Okay, we will only see the PQRST waves. Okay. Now we have a ECG paper here. As you can see, it's a lot of squares, right? So there are vertical lines and there are horizontal lines. The horizontal lines represents time, meaning it measures time in seconds. You observe there are small boxes and there are big boxes, correct? So this is a tiny ass box and this is a big ass box, right? Okay. So each small box measures 0.04 seconds. How much? 0.04. Okay. So therefore 0.04 seconds times 5. As you can see, there are 5 horizontal boxes in one big box, right? 1, 2, 3, 4, 5. So 0.04 seconds times 5 equals 0.2 seconds. So therefore, one big box is how long? 0.2 seconds, right? So therefore, in 1 second, how many big boxes are there? 1 second has how many big boxes? This is one big box, right? And you said one big box is how many seconds? 0.2 seconds. So therefore, in 1 second, how many big boxes are there? 5. How many small boxes are there in 1 second?
It's 20 bucks. No.
There's 5 in every 0.2. 25. Very good. Okay. Let's go now to a minute because how do we measure heart rate? Beats per what? Beats per minute. So therefore, how many small boxes are there in 60 seconds? If one small box is 0.04 seconds, how many small boxes are there in 60 seconds?
See, repeat the question again.
Okay. How many small boxes are there in 1 minute?
How many boxes in 1 minute, you said?
Small boxes.
300? It's not 300?
Each small box is 0.04 seconds.
Yes.
Each big box is 0.2. So yes, you're correct. There are 300 Big, sorry, let me finish. Let me see why you're wrong. Okay, so you're correct if you said there are 300 big boxes in 1 minute. I was asking how many small boxes are there in 1 minute?
So it's gonna be 300. 0.4.
There are 1,500 small boxes in 1 minute. And there are how many big boxes?
300.
300 big boxes in 1 minute. Are we clear?
Yes.
All right. So put those trivia facts aside for a while. We'll use that when we get to counting the heart rate, because there are a few steps we need to take in order to interpret a rhythm. So let's go back to the waves and complexes. So we have a PQRST wave, and then we just talked about what the horizontal axis means. So that is measuring what again? What does the horizontal lines measure? Time in seconds. Very good. Okay. Now you'll notice that each wave and complex seems to rise at a certain point from a imaginary straight line, correct? Meaning, how do you know this is the P wave? Because it started from here, from this imaginary straight line. Now, let's call that imaginary straight line the isoelectric line. Okay, isoelectric line. Now, let's go to the vertical lines. So we already talked about the horizontal lines. We know that is measuring what? Time in seconds. Now, let's go to the vertical lines. The vertical lines measures what? Voltage in millivolts. Okay. So therefore, one big box is measuring 0.5 millivolts, or this is also measuring 5 millimeters. So if you take a ruler or any measuring device, it will measure 5 millimeters. Okay. Any questions so far? When you look at an ECG, what are you really looking at? You are looking at horizontal lines and vertical lines. Vertical lines measure voltage, and horizontal lines measure time in seconds. Okay. Okay, let's look at now, what does each wave and complex represent? What are we looking at when we see a P wave, a QRST? What are we looking at? Okay, so a PQRST is a complete heartbeat. That is lub-dub, meaning blood came in and came out. That is one cardiac cycle. So one heartbeat is represented by a PQRST. Let's look at each wave and how they measure and what they represent. So the P wave, again, we will measure every wave and complex based on the isoelectric line. Now, don't take it literally, because this is an ECG paper, right? But this was drawn by somebody. You saw a real 12-lead ECG here. Now, if I magnify it, that's as close as I can get. I mean, that's as big as I can get. You see the P wave and the QRST and the T waves here? Does the P wave and any other complex here fall on a solid line? None of them do. So only here do you see them on a solid line. However, on a real ECG, they never fall on an exact straight line. So you'll have to make up your own isoelectric line, just estimate it. Okay, like for this, for instance, I can say, oh, this is the isoelectric line. Approximately, this is my isoelectric line. All right, so let's go back here. The P wave is measured from the time that it left the isoelectric line to when it returned to the isoelectric line. So if this is my P wave, where do I start measuring it? From here or here?
So from the first
From
one.
the second one.
From the second one, because this is where it started, this is where it left the isoelectric line. So it left here, went up. How many millimeters or millivolts did it go up? So if this is 0.5, one big box is 0.5, that means divided by 5, 0.1. So this one went up by 0.1 millivolts and then returned to the isoelectric line right here. So if you are to measure the P wave, how many seconds is this P wave?
It's gonna be 1, 2, 3. Wow. It's 3 batteries.
It's not 3. This is 1, 2, and a half. This is only 2.5 small boxes. That means 0.04 times 2.5 equals 10. 0.1. 0.1 seconds. Okay, very good. Correct. So what does it represent? It represents the time. Remember, this is all time. Okay, so horizontal line is time. So what is it? What time is it representing? It's representing the time that it takes for the impulse to leave the SA node and spread through the atria, because this thing represents atrial contraction or atrial depolarization. So what happened during the P wave? What happened during the P wave? When I see a P wave, what's happening here? What's contracting? Both atria are contracting. So is it good to see a P wave?
Yes.
Yes, I want to see a P wave. Do you want to see a P wave? Yes, because I know what two things am I sure of when I see a P wave? What's happening? I know the atria are contracting and I know where did the impulse come from? The SA node. Okay, so therefore the P wave, is it essential for any normal rhythm?
Yes.
Yes, I better see a P wave there. Because if I don't see a P wave, what two things are missing? The atria, are they contracting?
No.
They're not really contracting. And what's the other thing that's not happening? The impulse did not come from the SA node. So do I want a P wave?
Yes.
Do I like seeing a P wave?
Yes.
Yes, I want to see P waves. Because what two things are happening when I see a P wave again?
Contraction.
Atrial contraction and the impulse came from the SA node. So therefore, is it a normal beat? Yes, that beat was generated by my primary pacemaker and it made both atria contract. Very good. Now let's look at the second one. I'll skip the QRS complex first. I'll go through in order, okay? So before we can get to the QRST, there's this time period right here. So we call this the PR interval. Let's go to the PR interval down here. So what is the significance of a PR interval? What is it showing me? What does it mean? Remember, this is time, okay? These are all time. PR interval is measured from the beginning of the P wave to the beginning of the QRS. Right here. So therefore, when I measure the P wave of the PR interval, it includes the P, right?
Yes.
Okay, and then it stops right here, right before the Q wave begins. Now, this is one thing that will confuse people because it should have been called the PQ, correct?
Yes.
Because is it measuring the R?
No.
No, we're measuring from the P to this before the Q begins. So has it anything to do with the R wave?
No.
Not at all, but yet they call it the PR interval. Don't ask me to explain why, because I can't. Okay, so whoever named this, whoever wrote the book from the beginning, you ask them. They're all dead now, leaving us with nothing, but that's what they call it, PR interval. So what does the PR interval represent? So it includes the P wave, okay? It includes the time that it takes for the atria to contract, and then it's measured up to the the time that it reaches the AV node, meaning, let's go back here. So the PR interval, therefore, includes the atrial contraction plus the time that the same impulse reached the AV node. All right. And what is the normal duration of the PR interval? It's between 3 to 5 small boxes. 0.12 to 0.2 seconds. Okay, so that's between 3 and 5 small boxes. Okay, so why does it need to be between 3 and 5 small boxes? Now think about it. If this is the time that it takes from the impulse when the SA node fires an electrical impulse, reaches the AV node, that means what's happening during that time? Yes, atria contracted. And then what did the atria do to that blood when they contracted? They opened the AV valves and put the blood where? Into both ventricles. Okay, so is that important? Yes. Now imagine if there was no PR interval. Because like I said earlier, does it take long for lightning to strike, to appear and strike something in the horizon?
No.
No, it did not take long at all. Not even 0.2 seconds, okay, or 0.12 seconds. It happened really fast. So that means, what is the role of the AV node, therefore? The role of the AV node. Because it's supposed to transmit it, right? So I'm the AV node and Sasha is the SA node. So she delivered an electrical impulse, and then what did I do to it? Did I receive it and pass it directly? No, I did not. I delayed it by 0.12 to 0.2 seconds. Now, why did I delay it? Why did the AV node delay it? Imagine if there was no delay. Will our rhythm look like this? Will it look like this? Or will it look like after the P, it will be a Q right away? Correct? That would have been it. So is it gonna result in normal cardiac output, in normal blood flow through the heart? No. If there is no PR interval, that means both the atria and the ventricles will contract at exactly the same time. Would you agree?
Yeah.
Now imagine the chaos that would result from that. Imagine if both atria and ventricles, all four will contract at the same time. Will there be any blood movement at all? There will be chaos inside the heart. Will there be any cardiac output? Will there be any oxygen delivery to the lungs? No. Are we going to survive? Is the PR interval therefore important?
Yes.
Yes, we appreciate this delay. Okay, so PR interval, this is a time period, the time it takes the impulse from the SA node to reach the AV node. Therefore, there's a 0.12 to 0.2 second delay. So because of that delay, did it allow time for the blood to leave the atria and enter the ventricles?
Yes.
Yes, so do we want to see a PR interval?
Yes.
So what will happen if your PR interval is too short? So let's say in this heartbeat right here, if this is less than 0.12 seconds, this one here, from here to here, less than 0.12 seconds. Let's say it's only 0.1 seconds. That's short, right? What will happen to the heart rate?
Go faster.
It's very fast because now instead of your heartbeat looking like this, it will now look really, really close together. It will narrow because imagine if the PR intervals are very short, very narrow, that means the heartbeats will be faster, right? So what will happen therefore if your heart rate is 150, 160? What happens to cardiac output? Because is there enough time for the blood to transfer from the atria to the ventricles? There's no such time. So therefore, those who are health junkies here and then you go jogging, right? And you see people, right? They're counting the heart rate and still jogging, right? They want the heart rate to be really fast. What are you really doing to the PR interval? You're shortening the PR interval. So therefore, is it good? So now you understand why I don't jog. I want to promote my cardiac output. I don't want to narrow. No, I'm just kidding.
Okay.
But I'm just telling you, the higher your heart rate, the narrower the PR interval becomes. Okay, let's go to the next wave, the QRS. So what is the QRS complex? Again, we always measure things from when they leave the isoelectric line to when they return to the isoelectric line. So next up is the QRS. So we looked at the P and then the PR interval. Then let's look at what's happening during the QRS complex. So this is now the Q. So we measure it from here when it left the isoelectric line to when it returned right here. So the QRS is from here to here. What does the QRS complex represent? It represents ventricular depolarization, ventricular contraction. So the ventricles, both ventricles are contracting. What is its measurement? It's supposed to be less than 0.04 seconds. That's the Q wave. So all in all, the QRS complex should be about less than 0.12 seconds, less than 3 small boxes. Now, there are significance, of course, if it's too narrow or if it's too wide, it'll be explained at a later section of the chapter. Now, let's look at this can be distorted, meaning we can have abnormal QRS complexes. But this is what a QRS complex looks like. Look at the deflection. How many millivolts is it? So you can just imagine how much power there is in the ventricular contraction. Because look at by comparison, look at the P wave, the atrial contraction versus the ventricular contraction. Is there a big difference? Yeah, just look at the puny electrical activity during atrial contraction compared to the ventricles. Look at this. That's so much power. That's over 4 times more power, more electricity. So it represents ventricular contraction. Now let's look at the ST segment. The ST segment is this period here from the S wave to the beginning of the T. So it's normally isoelectric. So that means what's happening to the heart here during the ST segment period? Is it doing anything? It's resting. Okay, this is literally how long, look, so therefore, how long is the heart resting in between beats? 0.04 seconds. Your heart does get a rest, that's it. Imagine if you're going to sleep only for 0.04 seconds. Okay, yeah, I'm awake again, I'm awake again. That's all the sleep you get. So there's literally nothing happening. Of course, when there are changes to this ST segment, such as what happens in an MI, when the patient is having a heart attack, so a ST segment can be either depressed or elevated. So that's what we call ST elevation MI, which is a massive heart attack, versus a non-ST elevation MI, which is a less serious heart attack, meaning ST depression. So either ST depression, so what will it look like? So ST elevation MI looks like this. Look at the ST segment. It's supposed to be isoelectric. What's happening to it now? It's elevated. Okay, right here. Here's another example. So this is called ST elevation. This ST segment is supposed to be down here. Okay, it's supposed to be isoelectric. Now it's elevated. Now let's look at non-STEMI. It looks depressed now. So this is and with T wave inversion. This is T wave inversion. That's not a very good example. Let's look at another one. Right here. So here the ST segment is supposed to be isoelectric. Is it elevated? No, it is depressed, it's low. Okay, here's your T wave, supposed to be up here, right? Now it's depressed. And last one, this is it for today, the T wave. This is the T wave measured from the end of the ST segment. This is when the S wave left the isoelectric line, becomes the T wave. What does the T wave represent? And then it ends right here. T wave represents ventricular repolarization. So this means that the heart is not really resting. It's becoming more positively charged again because it became negative during the QRS complex. So because here it discharged all that energy, all that power that's been built up by the positive electrons, it let it go by contraction, depolarization, and then it has to repolarize for the next contraction, for the next heartbeat. So that's happening here. It's becoming more and more positively charged again. Okay, so from negative right here to now partially positive here. So it's beginning to get positively charged again. It's ready now for the next heartbeat. So therefore, when you see an ST inverted T wave, sorry, when you see a change like this one. So this T wave is supposed to be positive deflection, correct?
Yeah.
And when it's positive deflection, that means what's happening? It's becoming more and more positively charged, meaning it's starting to get repolarized. What's happening here if it's negative? Is it repolarizing? No, not at all. This indicates either a new or an old heart attack, meaning are there cells there? Are there ventricular cells that are not repolarizing at all? Yes, that's the indication. Again, what does it indicate? Either a new or recent or an old infarct. Meaning the patient must have suffered a heart attack now or recently or long ago. All right. So that means there are portions of the ventricles of this patient's heart that are now scar tissue. They are not repolarizing. They're just there, occupying space, but are they taking part in the contraction job? Are they contracting? No, they can't contract if they are not repolarizing. Okay, repolarization is essential for contraction. Okay, we'll end here and then we'll continue with counting the heart rate, and then we'll proceed with the common dysrhythmias next week.